enough to have Dr. Rosen-Carole here giving our grand rounds. She did her residency of pediatrics at Yale New Haven, and then was practicing as a pediatrician and residency faculty all the way up till 2014 at New Haven, Connecticut, and New York Hudson Valley before relocating to Rochester and doing a fellowship in breastfeeding medicine and general academic pediatrics. And she is now the medical director of lactation services and programs at the University of Rochester. And she's here to talk about breastfeeding and anesthesia. So thank you so much for joining us, Dr. Rosen-Carole. And please begin. Thank you.
Awesome. Thank you so much for having me. I am just thrilled. I'm going to start sharing my screen. And I think this, I'm just going to minimize the Zoom. This lecture is a little bit long overdue because you'll be seeing that we actually have some pretty interesting connections between our two divisions, which is, even though my division is very small and includes me and a current fellow, you'll see in a minute that we share a connection through the Lawrences. So the talk I'm giving today is Should I Pump and Dump, which seems to be the perennial question whenever mothers are going to have surgery or start new medications. And the questions can be very tricky. And I know I, for one, did not get a lot of exposure to this in medical school or residency. And a lot of questions come our way. And we actually have increasing amounts of data to support some of the decisions that we need to make. And so I'm going to go through some of those data today. Excuse me. I have one disclosure, which is that I'm on the medical board for a biotech startup for Mayan Meadow, which is works on breastfeeding technologies, and I'm grant funded through Bill and Melinda Gates and NIAID for coronavirus and breast milk research. So the elephant in the room whenever we talk about breastfeeding is that we were all at one point mothers or babies, and so breastfeeding affected us all. And sometimes those experiences are lovely, and sometimes those experiences are not, and devastating. And what we do here when we're talking about lactation medicine is really use our own personal experiences to inform our approach and our empathy to patients, and then use data to help us really come up with the recommendations that we make. But it's a heavily charged subject for our patients and ourselves. And I think it's really important to acknowledge that whenever we're starting to think about these complicated scenarios. To talk about two other giants in the field, this is how our divisions are related. Of course, you all will recognize Robert Lawrence, who I never got to meet. I came to Rochester later, and about 5 years ago. And he had already passed, but as you know, he was the first resident in anesthesia. He came out of the Korean War, noticing that while surgeons might be able to save people, anesthesiologists were needed to keep them alive. And that surgery was no good if you couldn't help the patient continue to breathe and continue to have strong blood pressure throughout their surgery. And so you continue, I think, in your department to have an award in his name, and his wife is Dr. Ruth Lawrence. And she was a giant in my very small field of breastfeeding medicine. She was trained at Yale and trained with E.D. Jackson, who brought rooming in to the United States after doing a fellowship in Germany with the Freuds. And Ruth Lawrence made many of the first organizations surrounding breastfeeding and medical care, and the first textbook, which is coming out with its next edition this fall. And she just retired in January, and the two of them were certainly a powerhouse. And so one of the things that I like to talk about when I'm talking with anesthesiologists is, what is pump and dump? And when I was doing research for this talk, pump and dump is actually another term for securities fraud. but it's also an outdated approach to breastfeeding moms. And one recent post that was kind of interesting, and it's sort of important to bring up, is that very few moms are this happy about pumping and dumping. This was an Instagram post, hashtag pump and dump. Um, this woman is the wife of Adam Levine, who went to a concert and was very happy that day. And very few of our patients are going to be this happy about being told to pump and dump. And the other reason I like to bring up what's going on with pumping and dumping in the media is a lot of people reacted to this, that, of course, judging, which is unfortunate, that she didn't need to pump and dump. And so this conversation is out there. This is even a post from a Facebook website. So even if we might not be sure about pumping and dumping, there are resources out there that our breastfeeding mothers are exposed to surrounding whether or not they should be able to continue to breastfeed while they are under anesthesia. And so what is the harm in being conservative? I think a lot of people will say, oh, just to be safe, why don't you pump and dump, for 24 hours? Or just to be safe, why don't you pump and dump twice, right? And we consider this to be a conservative approach, and I hope you'll understand by the end of this talk that I think that this might be actually not a conservative approach, but potentially a harmful one. The harm in being conservative is that mothers may stop their medications entirely, and I've had moms stop important medications when they've been told that they might have to interrupt breastfeeding for them. And generally, as physicians, we don't start medications unless they're important for the health of the parent. So this is one unintentional side effect that we might have from having an overly conservative approach. On the other hand, mothers might stop nursing on their own, and healthcare practitioners who are concerned about adverse effects may encourage pauses or cessation. And formula and breast milk, as you'll see in a few minutes, are not equivalent. And abrupt weaning can result in engorgement and mastitis, which are definitely real and definitely preventable in most cases. Also, we rely on the information that drug manufacturers use, and until recently, they didn't actually have to say anything about breastfeeding. The FDA created rules a couple of years ago that now they actually have to say whether they have done any breastfeeding research, but really drug manufacturers push off the risk onto physicians and parents and are not doing adequate research in this area. So before we get into a little bit more about the medications, I'd like to talk a little bit about why our patients are breastfeeding at all, right? So the benefits as opposed to the risks, recommendations, and just to be clear what the contraindications are so that we can do a little refresher. So why do we talk about breastfeeding? I'm sure you all are very well versed in this, being both from Rochester, which has had the benefit of the Lawrences for the past 50 years, but also the media. You tend to see all of these things listed, reducing the risk of all of these chronic medical diseases and potentially improving school achievement, socioeconomic status, and bonding. But, are these really benefits of breastfeeding, or are they risks of formula feeding? And of course, this is not something that I would bring up with a patient at 3 a.m. whose baby can't latch and everybody's crying, but the risk-based language is actually increasingly being used. The Joint Commission required risk-based language for prenatal care and decision-making, and that started maybe 5 to 10 years ago. And so patients are exposed to risk-based language, which I think has some consequences. Some of them include the fact that I see a fair number of babies with failure to thrive because people are worried about formula, but also if you're talking about stopping breastfeeding for a period of time, you might realize that patients will be very scared to consider a medication, or they would be very scared to stop breastfeeding or pause breastfeeding. The recommendations for breastfeeding is 6 months of exclusive breastfeeding, and then the AAP and the WHO differ about the strength of the data about whether people should go to at least 1 year or at least 2 years. And then both of these end with a sentence that says, or as long as mom and baby desire. And we have good data that continuing to breastfeed does not create negative psychological consequences. And there is positive long-term evidence to breastfeed out to 3 years and beyond. And so it becomes a matter of the personal dynamic at that point. There are only 5 true medical contraindications to breastfeeding. If the infant has galactosemia, except for the partial variant, and then the rest are if the mother or the parent has HIV or HTLV1 or 2. And that is at this point in the high-income countries, a contraindication. In low-income countries, HIV is not a contraindication to breastfeeding because, of course, the leading cause of death in infants in those countries is diarrheal illnesses. And in the United States, with the 0 = 0 movement, there is increasing discussion about women with HIV potentially at some point being able to breastfeed. Untreated active tuberculosis, use or dependence on an illicit drug, which gets a little bit complicated as we start legalizing marijuana in this country, and then use of cancer chemotherapy and some types of radiation. So a little bit about why breast milk and formula are not equivalent. Human milk is really a biodynamic substance. So yes, like formula, it has the nutrients, it has the proteins and the lipids and the carbohydrates, but it also has all this other stuff in it. It has immune-related compounds. I do research in secretory IgA and cortisol. It has cells, it has fatty acids and enzymes and coenzymes and hormones and growth factors. It has the all-important microbiome, and as we're learning about human milk oligosaccharides, which play an interesting and important role. And so we can really think of human milk as both nutrition, which is consistent with what formula would be, but also as immunity and also as signaling. And we have increasing evidence, and this is the work that I'm doing in signaling, that these compounds are actually changing outcomes for infants in the short and long terms. It changes based on phase of lactation. So some of you might recognize that on the left we have colostrum or transitional milk, and on the right we have more mature milk. When you're pumping, you're going to see a difference between the milk that comes out first and the milk that comes out towards the end of the pump, which people call foremilk and hind milk. And these are samples between mothers. This is what we call a chromatocrit. And it's when you spin down the tubes of breast milk and you're looking to see the fatty composition. And so in between mothers, the fat distribution and many of the signaling will be different. And human milk really is species specific, so it kind of reminds us that we really are mammals. And the reason that we chose cow milk to create most of our formulas is really both because you can obtain a lot of it, but also that it is the closest in caloric content and fat content. But it's very different in terms of lactose and protein, and this is part of the reason that it has to undergo such manufacture before it's acceptable for infants. And I always like to just remind people that this is being species specific. It also has impacts on how we have to feed and how we parent. And so we have the species that feed less often will have far more protein and fat in their breast milk. And so interestingly, for the whales and the sea mammals, they will hide their babies in the snow and they will feed maybe once a week. And it's just very high fat, high protein milk. Dr. Lawrence would say that you could cut the milk with a butter knife. Whereas the cached feeders like rats and rabbits will feed once a day, and then they keep the prey away by, running away from the burrow rather than keeping the animals there. But if you see that the primates are way down here, we have low fat, low protein milk, which suggests that frequent feeding and carrying is really important in the maintenance of lactation and the health of the babies. Now, what does this mean? This means that if you're, expected to feed your baby physiologically every 2 to 4 hours, a 6-hour surgery might really get in the way with that lactational physiology. In addition, human milk and formula are not equivalent. And you can all take your time to read through this a little bit later, but essentially formula doesn't have variation. It has fewer components, it's not bioactive, and there's a lot more waste. And this is a picture that I love to show. Nancy Wright is a colleague, and she just put some slides under a microscope and showed, it just gives a nice visual representation that human milk is a biodynamic substance with a lot of fatty globules and cells, as opposed to the more homogeneous infant formula, which is nutritive. In addition to which, mother's own milk and donor milk are not equivalent. So mother's own milk will continue to have that variation. So this is particularly important in the NICU, time of day, gestational age, maternal condition, whereas donor milk will have much more limited variation, being pasteurized and often grouped between a bunch of different mothers. They pasteurize, which takes out a lot of the immune factors and certainly kills off the microbiome. And whereas mother's milk is sensitive to feedback, meaning if infants nurse more often, it will go up, the caloric content will go up, the fat will go up. It will create immunoglobulins based on infant viral exposures. Donor milk will not have that feedback. So before we move into the medications, just one more little bit about lactational physiology. This on the left is just a reminder of those cycles that we see in medical school, right? That the pituitary is responsible for the hormonal control of lactation, and that when milk is ejected, you get the positive feedback. But there is also a negative feedback loop, meaning that if you're not emptying the breast, then you'll get negative feedback, and you will decrease the amount of milk that you make, and that's called weaning, right? And so when we think about asking someone to abruptly wean or to pause from lactation without encouraging them to continue to pump or empty their breasts some other way, when lactation is not well established, this could lead to low milk supply, which could lead to underfeeding, failure to thrive, or unnecessary formula supplementation. And when lactation is well established, it could lead to engorgement, pain, and mastitis. So now we get into the heart of the issue for anesthesiologists, and we're looking at the medications and breastfeeding. So what we'll talk about first is how do the meds get into the milk? What are the effects that we're looking at? And then we'll go into specific agents that you'll be using in your ORs and some recommendations for how surgeries might be able to be planned so that lactating people have the least impact on their health and well-being and those of their infants and children. So in terms of the biomechanics, when we think about whether a medication is going to get into human milk, we know that we can't rely on the pharmaceutical companies, and many of the research studies that we'd like to see have not been done. And so we really need to understand how milk can have medication in it. And essentially, for almost every medication, it's a process of diffusion. And so it's very similar if you think about alcohol getting into the bloodstream and then passing out of the bloodstream as it gets metabolized. As an example, alcohol, as the concentration in the blood gets higher, many people know you don't have to pump and dump for a drink anymore because it diffuses into the breast milk, and then it diffuses out of the breast milk as the liver metabolizes the alcoholic drink. There are very few medications that have active transport. Iodine is one of them, and by very few, I mean like iodine compounds and tagged iodine compounds. So if we're thinking about a process of diffusion, then we need to know that drugs will transfer into human milk if they get high concentrations in maternal plasma. They also need to be a certain size. So anything less than 600 to 800 kilodaltons has a good chance of getting into the milk. Bigger things, we're talking like immunoglobulins, those kinds of things are hundreds of thousands of base pairs and they don't get into milk. Things that are not protein bound are more likely to diffuse. Things with high pKa are potentially going to become ion trapped in milk, and things that have high lipid solubility, right, are more able to pass membranes. And then it's really important to think, okay, let's say it does get into the milk. Can it be even absorbed by the baby? And so, as you know, many of the agents you give, you can't give orally because people would not absorb them. Similarly, therefore, if a little bit did get into the milk, and we're talking generally, these are less than 10% passage, would the infant even be able to absorb it? And so it's important to know whether there's high oral bioavailability. So general principles, we avoid drugs when possible, but most drugs are safe, as opposed to the risks of formula, which are well documented. We prefer medications that have a relative infant dose. So you can imagine that's just a calculation based on maternal dose. How much would potentially enter into the milk and be and expose the infant. So relative infant dose of less than 10%, short half-lives, high protein binding, low oral bioavailability, and high molecular weight. We obviously always start with data-driven recommendations, and I'll show you Lactamed in a minute. And we're cautious, a little bit more cautious with premature infants or neonates. And the other thing is potentially, especially around birth, if the question is ever whether a mother can breastfeed, are we going to allow her to breastfeed and she just gave birth? The answer tends to be always initiate, right? Because colostrum is very, very low volume. So even if you have a relative infant dose of 11%, we're talking teaspoons at this point. And then we can have conversations with the parent if we have concerns as we make the decisions based on the biomechanics. The other thing we can do is we can adjust to the schedule of the baby and the parent. So for instance, if you have something that has a short half-life, like a pain medication, potentially you could avoid the peak. So you could say, you know, yes, this medication is of concern, but we know that it peaks within 2 hours and that the half-life is, you know, about 4 hours. So could you take a 4 to 6 hour break from nursing? And generally that would be taking something at night right before the baby's longest stretch of sleep. So when we think about medications and breastfeeding, we tend to focus on the infants, right? And the things that we're really worried about are especially drowsiness and apnea, right? And then potentially we're worried about them eating and growing and the quantity of breast milk that they're getting. And then in terms of lactation, we also need to think about, could this drug affect milk production, or you know, could it increase milk production, and which could potentially lead to engorgement and mastitis, or could it decrease? And so the things that tend to decrease would be like diuretics, antihistamines, decongestants. So anything that seems to be drying up our secretory system, right? And then certainly estrogen, because that will interrupt the hormonal pathways. There are galactagogues, and we do use Reglan and domperidone, and some patients take herbals to make more milk. So if you had a patient with nausea and she was being given some Reglan, if she has oversupply, that would be something to know. Again, thinking about timing and half-lives. So what resources exist? So the NIH has a ToxNet breakout called Lactamed, and you can get it as an app on your phone. And it reviews the most current literature surrounding lactation and medication. What's interesting about Lactamed is that sometimes people find it a little bit difficult because it doesn't give you a yes or a no. And if you really need a yes or a no, there are people who do that. And so you can call the Lactation Study Center, where we take calls for medications and breastfeeding and pregnancy, or you can call the UR of our breastfeeding clinic. So we do prenatal visits, we do postpartum visits. And so if we have patients who are expecting to be on a medication that they need some more answers for, we can do visits or we can consult by phone. So a few examples now. I'm just going to check and see how I'm doing for time. All right, good. So this is the stuff you've probably all been waiting for, because it's the most specific to your field. So we're going to talk about anesthesia, analgesia, procedures, and surgery, and just a little bit about radiation, because your patients will be undergoing other things as well. So there is a Academy of Breastfeeding Medicine, of which I'm part, and we put out clinical protocols, and these are freely available online. And they recently revised the analgesia and anesthesia for the breastfeeding mother. So the Academy of Breastfeeding Medicine is a group of people who are not necessarily like me doing full-time breastfeeding medicine, but have a strong interest in breastfeeding medicine research and advocacy. Sarah Rees-Stretman, the primary author, is an anesthesiologist and treasurer of the Academy of Breastfeeding Medicine. And there are protocols on everything from mastitis to drug use, illicit drug use. And so this is a really useful resource where it looks at the most recent evidence surrounding analgesia and anesthesia and some tips for caring for people who are undergoing surgery. So in terms of anesthesia, if you're looking at brief local anesthesia, there really is little concern. In terms of IV medications or inhaled medications, as soon as a patient is awake, stable, and alert, she should be able to breastfeed. And I'll go into that a little bit more in a bit. Again, we are a little bit more concerned about premature infants and newborns. And so if there are infants who have apnea, maybe they have apneas and Brady's, and that's why they're sitting in the NICU on a monitor, we might be a little bit more careful in terms of giving them breast milk that was pumped surrounding anesthesia. And so what we need to ask when we're thinking about using these agents in breastfeeding moms is, if we are going to interrupt, what should they be doing instead, and how should they prepare? And I've unfortunately had many cases, no matter where I've practiced, where patients come in and say, you know, in panic, I was told to stop breastfeeding for 24 hours and I don't have a pump, or I don't know what to do next. And I've had cases of mastitis where people just did what they could and ended up engorged and with mastitis. And so we really need to think about, if we are going to ask for an interruption, what are we going to be doing instead? So again, this is the LactMed. If you are more interested in making these decisions routinely yourself, instead of calling the Lactation Study Center, there's another online resource. Some people might have heard Medications in Mother's Milk. It was the first book out by Tom Hale, who is a PhD pharmacist in Texas. And he now has an online database. One of the things that I really like about his database is that, as you can see on the lower right-hand corner, he will give some of the biomechanics. And so while LactMed...
Sorry to interrupt. Can you share your slides with us again? I apologize that they're not on the screen.
Oh, no. What happened? Are we there?
Yes, thank you.
Okay, I'm so sorry. So this is, so this is the clinical protocol. And then here are the resources. So this is Medications in Mother's Milk. And what I love about it is it will have whatever data we do know from either studies or the drug manufacturer about the half-life, about oral bioavailability, pKa, time to max. It will have relative infant dose. And then Dr. Hale also gives these categories that he has created. L1 is absolutely considered safe for breastfeeding. L2 might have some minor concerns around milk supply, for instance, like Claritin, Zyrtec, those kinds of things. Zoloft would be an L2, right? It's not like drinking water, but it's pretty safe for breastfeeding. L3 is his category for things that don't have data but are probably okay. And then as you get into the L4s, L5s, and L6s, you get into things where you really need to consider whether you're going to pause breastfeeding or consider a different medication option. Both of these resources will have lists of other options you could use instead. And then this is a really nice review from 2015 about breastfeeding after anesthesia. So that's a nice resource. And I have the links for all the resources at the end of the presentation. So when we're thinking about induction agents, I'm going to go through a little bit of data about the things that you tend to use very quickly. And one of the things that you'll see is that, as you know, and this is the reason that you're using them, is that they're pretty fast, right? They have rapid metabolism. Propofol, for instance, doesn't have an active metabolite. And breast milk concentrations in studies have been shown to be negligible 2 hours after delivery. It also has a very low oral bioavailability and rapid metabolism in infants, so it's generally considered safe for the breastfeeding parents. So etomidate, there's been some studies in breast milk looking at elective C-sections patients' breast milk after an induction dose. And 30 minutes after the dose, the milk to plasma ratio was 1.2, but then it decreased by 75% after 2 hours and was undetectable at 4. So again, likely a pretty safe induction agent. Although there have been no studies on ketamine in breast milk, it does have a very short half-life and a short redistribution half-life, so it is also considered acceptable. And midazolam is one of the preferred agents because it has a low milk to plasma ratio and low oral bioavailability. It's also fast. And there have been a few studies of moms taking midazolam, and they found that the relative infant dose was 0.004% of the maternal dose. So very, very low. Volatile agents, as you know better than I, are quick in and quick out. So although there are no studies in human milk, we in the breastfeeding medicine field don't think that this should scare us quite as much because they are rapidly excreted and have very poor bioavailability. And as we know that as the partial pressure, it comes out of the blood, then there's clearance. And so if there's clearance in the blood, there's going to be clearance in the milk. And this is the basis of why we say that as soon as the mother is awake and alert, she should be able to breastfeed without being too worried that her baby will be exposed to these things. Opioids, we get into a little bit more risk for infants. And there are preferred agents. So fentanyl is highly lipophilic and stored in breast tissue, but it does have low bioavailability and a short duration of action. And so there have been a few case series where women were given fentanyl and then their breast milk was measured at time points over 24 hours, and they did find a very low, as you'll see, relative infant dose. Morphine and hydromorphone we'll go into a little bit more in a minute, but there have been no studies using this as a balanced anesthetic during cesarean delivery with respect to what happens in the breast milk. And then remifentanil, again, no studies evaluating concentrations in breast milk, but it does have an ultra short half-life, rapid metabolism, and high protein binding. And there was one small study, which I'm sure you're more familiar with than I am, of patient-controlled remifentanil during delivery and no difference in APGAR scores in the babies. Now, APGAR scores is a little bit of a lower bar to make sure that babies have as compared to their suckling reflexes, which I'll show in a minute. But there were 4 women in a case series who used an IV infusion during surgery, and infants were breastfed with no respiratory side effects noted. When you're thinking about your neuromuscular blocking agents and your reversal agents, again, no studies, but we're thinking that they're unlikely to cross the blood-milk barrier because they're large and have low lipid solubility and they're polarized. They also have low oral bioavailability. So again, if they are to pass to the infants, we doubt that they would be able to absorb them very much. We can also liken the milk plasma barrier to the blood-brain barrier. And so things that are unlikely to penetrate the blood-brain barrier are unlikely to cross into milk as well. There was one case of neonatal abdominal cramping reported in, I'm sorry, not one, this was a case series as well, in a few myasthenia gravis patients taking cholinesterase inhibitors. But when they checked the breast milk, and when they checked the infant serum, they did not find the cholinesterase compounds. In terms of regional nerve blocks, I've already said we don't tend to consider these of high risk for breastfeeding. Again, no studies. I'm happy to engage in research if anybody's interested, but there are low plasma levels and low oral bioavailability. And so there was one case report where a mother had a cholecystectomy, and post-operatively, they checked the plasma and the breast milk, the plasma of the mother and the breast milk, and they found higher levels, but within 5 hours it was undetectable. And later it was undetectable in the infant's blood. And so we don't tend to recommend cessation of breastfeeding for regional nerve blocks. Again, we're looking at the clinical protocol. So when people undergo things that they need anesthesia for, they tend to also need analgesia. As I'm sure you all do, you know, starting with NSAIDs tends to be the best, but after surgery, that often doesn't cut it. So we're talking about hopefully using the shortest course possible, which I'm sure all of you do anyway. And the highest concern would be opioids for longer periods. So IV medications, although we will be cautious with the dosing that mothers are getting and the timing of nursing, morphine and fentanyl do tend to be preferred. And for PO medications, morphine, hydrocodone, and gabapentin tend to be preferred. And some researchers will say that they find that hydromorphone might have a better biomechanics, pharmaceutical kinetic profile for breastfeeding. And so people don't necessarily agree on this. I know at our hospital, there are a certain amount of moms who are using dilaudid PCAs after surgery, and we do work with them in breastfeeding. Certainly things to avoid. There are two that we recommend avoiding in breastfeeding, which are meperidine and codeine. Meperidine has a long half-life. I don't know if you use it outside of the context of breastfeeding, but there are lots of variable half-lives. And there is a report of cyanosis and bradycardia and apnea in infants exposed to moms who have used meperidine. Same thing with codeine. There have been cases of infants who have had respiratory depression or death in mothers who have used codeine for all the reasons we know that we're using less codeine these days. Because your patients are likely to be undergoing radiation as well, I thought that I would throw this slide in. We used to be very cautious about radiation. I still see patients who are told to stop breastfeeding for radiation, but we no longer recommend cessation of breastfeeding or a pause in breastfeeding for gadolinium or even any kind of iodinated contrast. They do not tend to be excreted in breast milk. They do not tend to be absorbed in infants, and there are no reports of harm. And both ACOG and the American College of Radiology agree on this. The one thing that sometimes we are concerned about are the radionucleotide compounds, which makes sense. And they're also excreted variously, so it wasn't easy to come up with a standard recommendation about how long the pause should be. But again, you can call us at the Lactation Study Center and we're happy to do the background work for you. You also get an email with the references that we've used if you do contact us, so that can be a useful resource. So whenever we're thinking about the broader context, having gone to surgery and have my family members gone to surgery several times, I do know that the anesthesiologist is a huge part of the preparation for surgery, right? The time in the OR and then, of course, the time after. And so when we're thinking about our hospital and bringing lactating patients in for surgeries and procedures, as anesthesiologists, you have the unique opportunity to make sure that people who are lactating are prepared, right? So if the surgery or the procedure is going to be longer than 2 to 4 hours, and generally, even if it's not, the wait time will be, we need to think about, what is the baby going to eat while you're apart? Has the baby ever had a bottle? And if they have issues with that, they can also visit us for preparation. We will do surgical consults, even just by phone, to help people get prepared for the day of surgery. So storing some milk ahead of time, getting the baby used to a bottle ahead of time, thinking about what medications they're going to take before, during, and after, and how that might impact their milk. And then considering the length of the procedure or surgery, again, or the wait time. So if a patient has breastfed at 8 a.m., comes in for a 10 a.m. surgery, there's a 1 to 2 hour delay, potentially that patient could miss 3 or 4 nursing sessions, which could set them up for some severe side effects with engorgement and mastitis and pain. And so we are happy to deliver pumps to the ORs, and you can also make sure that people bring their own pumps with them because they'll need to pump while they're waiting. We also will help with pumping during surgery, and I'd be interested during the Q&A to hear whether some of you have had people get pumped during surgery. Generally, people will use the hospital grade pumps for this, and we'll roll a pump in, particularly for the longer surgeries. In hospital, so if you're not at Sawgrass, we have lactation consultants who can come and help with any part of the stay or the surgery. And then when it's not coronavirus, we try to minimize separation. And so we do tend to recommend that if a mother is readmitted, particularly within the first 3 months after birth and she's lactating and breastfeeding, that the baby can stay too. And so we have these policies in place. So who decides what medications are going to be used, what they're going to do for breastfeeding? And there's lots of people in the mix, and this gets very confusing to parents. And in fact, it's really confusing if they get split. So if the surgeon says one thing and the anesthesiologist says another thing, or if the lactation consultant generally, will call me in a panic saying, this mom is being told to stop breastfeeding, but I thought gadolinium was okay. And my goal with being the director of lactation services and programs and seeing patients for this is to make sure that we are consistent and that we don't split people. I want people to have faith in their physicians. If you're going under the knife, you need to feel safe with your surgeons and your anesthesiologists. And so we take the approach that if I disagree with a surgeon or an anesthesiologist, I will call them and have a conversation, because I too have lots of things to learn in life, because I think the patient-physician relationship is paramount. So, but the parent is still going to get really confused. And when we present something as having any risk, most patients are going to knee-jerk to fear and to stopping. So even if we say, oh, there might be some risk and you could stop for 8 hours, they'll probably stop for 16 hours. And when we say any risk, as I presented earlier, that actually could be increasing their risk, right? It could increase their risk of using formula. They could decrease their risk by using their own stored milk. And some people will even use informally donated milk, which, if they are not aware of the potential consequences of that, we need to have these conversations. And so I think we need to be really clear that if we are not sure of the answer, that we'll find the answer for them, and just be really clear about what we think the actual risk is and how they can be best prepared. So here's an example from our hospital that I thought would just give us a sense of how this actually works out as you're going through the flow of your day. So a mom needs a scope. An infant is in the NICU, gestational age is 27 weeks. So considerations, the things that I'm thinking about when somebody comes to me with this case does her underlying disorder affect breast milk? Do I need to be thinking about the milk that she's already pumped? If she's going to be sedated, if she's going to have pain control, what are the types and how likely are they going to pass? How long is her wait time going to be? It's probably going to be pretty fast for a scope. How much milk does she have stored? Do we need to get ready for this for a week beforehand by pumping a little bit more or using galactagogues? Does she have low milk supply? Is she using donor milk? And then what her recovery looks like and follow-up. If she needs any procedures, will this impact her stress level and her milk supply and her ability to care for her baby? So I think we have a little bit of time to also talk about anesthesia during birth, which, again, I'm sure you're much more well-versed in than I am. I follow the literature, particularly surrounding breastfeeding. So I think it's important to just talk about and make sure we're on the same page about. And again, I have things to learn as well. So if you disagree with anything that I'm presenting, please bring it up in Q&A. So when we're looking at neuraxial anesthesia, we already talked about the locals, right? But when we're talking about opioids, both intrathecal and epidural have been shown to be safely used. The drug in maternal milk is generally undetectable in the case series that these have been studied in. But there are a few things to think about. For instance, limiting the amount of dosed and redosed medication can be helpful, because some of the studies have shown a little bit of difficulty in infants establishing suck when there have been higher redoses. And so even a conservative approach will say that moms may breastfeed postoperatively as soon as they're adequately alert and oriented. And we'll talk a little bit about breastfeeding in the OR as well. Fentanyl is, as we said, lipophilic and could potentially be stored. And so it's something to think about, that it could become slowly released into breast milk, as opposed to morphine, which has a moderate range oral bioavailability, and it also has a pharmacologically active metabolite, which passes in breast milk. And so the half-life of breast milk morphine is about 180 minutes, which is a little bit long if you're thinking about newborns nursing every 2 hours. So there's a series of studies that were done in the early 2000s looking at the infant breastfeeding assessment tool. And this is really about readiness to feed, whether the babies are waking up and rooting and latching and sucking, right? And in this one study that I'm going to show you, the mothers and the nurses both assessed using the validated scale, which will give you a score. And you'll see on the upper right-hand corner the different parameters that are used, and you can either get like a 0, 1, a 2, or a 3, the higher being the most active babies at the breast, right? And so you're looking at cues and you're looking at what they actually do at the breast. And, you know, it's possible that some of the anesthetics might have some effect on the baby's rooting reflexes. So in this one study, after controlling for infant age, birth weight, and gender, the unmedicated infants did have higher scores as opposed to the infants who had IV or epidural anesthesia during birth. Now, breastfeeding duration didn't differ, and this is something we routinely see, not just in this one study, which I wanted to show you just for sake of clarity, but in other studies about epidurals and breastfeeding, right? We're not seeing that the epidural affects how long somebody can then breastfeed, but we are wondering if it does mean that you need a little bit more support in the beginning. And a lot of our inpatient lactation consultants will tell you that this is something that they see on the ground as well. Interestingly, diettes who have this low IBFAT score, the infant breastfeeding assessment tool score, do wean earlier, so they have a shorter duration. So statistically, how that works out, it's an intermediate outcome, but still interesting to think about. And so when we look at the reviews, and these are the references at the bottom, really the results are inconsistent at this point because of the differences in study design and endpoints. There was one 2016 systematic review looking at 23 studies, and 12 found negative associations, while 10 found no effect and 1 found a positive association. So if you're looking at, the way the needle's going, it's quite possible that some of these anesthetic agents that we're using and protocols that we're using are having some effect. The dosing, there was one article looking at the dosing showing no association between the cumulative fentanyl dose and the rate of breastfeeding. And again, we haven't necessarily seen the outcomes in duration, but more often in the baby's activity, exclusive breastfeeding in the hospital. The other thing to keep in mind is that many people will use IV fluids, right, when they're doing some of these epidurals. And we do find that excess fluid can lead to engorgement, which is really hard to help a baby latch to a very engorged, firm, flat breast. And it's hard for the milk to come out because that interstitial edema impacts the milk ducts. The other thing that, of course, we know is that if you get a lot of IV fluids, then the newborn's going to look like it's lost a lot more weight, which might result in increased supplementation. I'm sure you all do this already, but just a note on fasting. Infants for breastfeeding will say, you know, breast milk is fine up to 4 hours before a surgery. But some of the things that we might not have thought about is, what if the baby's asleep? And so, you know, as breastfeeding advocates, we do tend to recommend waking that baby to feed them at the 4-hour mark, because it can be easier for the baby, but also easier on the mother's breasts. For moms, fasting might impact her milk supply, right? And also she might feel worse when she pumps, because you can get some milk ejection reflex side effects, particularly if you're fasting, some nausea, some lightheadedness. So those are other things to understand about asking a lactating mom to fast. Now, skin to skin in the OR is something that I know we're doing here at Strong. It's resulted in a lot of evidence showing higher BGs and more stable temps in the babies and improved first breastfeeding. Also, it impacts breastfeeding in duration, so you can have a longer breastfeeding duration. The Cochrane will tell you that, you know, more evidence is needed on this practice, but that babies do maintain their temperature, and that it does appear to improve the transition to extrauterine life. So I would encourage that we continue to encourage skin to skin in the OR. Here are some of the things that I've referenced. I thought if this was recorded, you could go back and take a look at the articles yourselves. And I would love to hear any questions that you'd have to share with me. Thank you so much for having me again.
Thank you so much. That was an excellent talk. It looks like if you open up the chat box, there are a few questions there for you.
Oh, sure, I can do that. I'm going to try to not lose my presentation mode. Oh, see, I already just did, didn't I? Here we are. Chat. 6 questions. Okay. Share my screen. Done. Contraindications with Dilaudid. So Dilaudid is tricky, as I was talking about with the when we were talking about hydromorphone. The only studies that have been done with Dilaudid are the mothers were dosed intranasally in terms of studies with breast milk, that is. So they were dosed intranasally or PO. And it looks like the maximum acceptable dose before the milk started showing higher doses, milk plasma ratios, was about 2, right, in about 4 hours. But that's not IV. And so it's very tricky for me to assess whether Dilaudid, so I don't think it's contraindicated, but it's very hard to assess the maximal dose. One of the things that I think is really important is I think people should take their medications, and I think people should have their pain controlled. And so I'm really, really happy to have these conversations after birth or after surgeries to talk about what is going to be the best way to make sure that both of those things are met. So not contraindicated, but we don't have enough data to make a decision about like a Dilaudid PCA, for instance. When I'm consulted, I'll come, we'll interview the PCA, we look at how the baby's doing, we look at where the baby is, right? So for instance, I've had a mom on a Dilaudid PCA whose baby was an ex-preterm who was at home with a caregiver that the mom wasn't sure. I mean, she trusted the caregiver, but she wasn't sure that they would be able to pick up on respiratory depression if it happened. So she chose to pump and store and use older milk and formula until she was able to leave. I've had another mom who had a Dilaudid PCA after birth. She was a chronic opioid user before birth, and so she had a relatively high tolerance. And then, but the baby was with us, and so we were able to observe the baby for side effects, and we were able to see if we could keep her within that 2 milligram window. So I hope that answers your question. Do we have a high yield peri-op pamphlet? No, and I'd be happy to create one. I would need a little bit of help from maybe a volunteer. It looks like that question was for Heather Lander, so maybe Heather Lander is volunteering. But my group has created different handouts for different departments. We have one, for instance, for multiple sclerosis and rheumatoid arthritis. We did one with neurology, right? We did one with rheumatology. I just need a little bit of guidance. Any other questions? Well, you get 8 extra minutes for your coffee before your first cases. So.
Dr. Rosen-Carole, thank you so much. That was an incredibly great presentation and very, very useful for all of us. So
Absolutely.
thanks again for agreeing to do this. That was a great presentation.
Oh, I was so pleased that you had me. Thank you so much. And if someone could reach out with who I can contact for the pamphlet, I'd be happy to help.
Absolutely. I think Heather Lander asked a question, but it looks like Renee Robinson from our perioperative clinic was offering to help with that too. So we'll be in contact with you. Thank you so much.
Thanks a lot. Have a great day.
You too.
Bye.